We are happy to see you. And here, they're going to introduce themselves. And later, we will request you introduce yourself too, because we need to know you and where you come from.
Okay.
I'm Simon.
Simon.
Juma. Elifaz. Joseph. Romis. Abakuchi.
William.
Tito. Jackson.
Violet. Generosa. Ivasi. Zawadi. Violet. Sharon. Alice. Mercury. Beatrice. Adrian. Aren. Goretti. Kasari. Penina. Christine. Shareni.
Wow. So what is the meaning of doing this?
It's a hi to you.
From behind. Try again.
Auntie Kathy. Auntie Kathy. Auntie Kathy. Auntie Kathy. Auntie Kathy. Auntie Kathy. Auntie Kathy.
Okay. Good evening, everybody. I'm Kathy Lee. I'm the founder of the Justice for Women lecture series. I want to thank you all for joining us this evening. Maine Law has been the home for the Justice for Women program since we began 15 years ago. Law School Dean Lee Softly welcomes you to this event every year, but unfortunately, an important family matter prevents her from joining us tonight, but she sends her apologies to our speaker and her thanks. This evening, we're going to hear an informative presentation about healthcare challenges in rural Uganda. These challenges are as real there as they are here, and you'll be surprised to learn how many of them are the same. We've been learning from healthcare providers in Maine all week long that solutions that our speaker has pioneered in Uganda might well help us solve some of our healthcare problems here in Maine. Before we begin the program, I just want to thank a few people who make this event possible every year. Maine Law staff, Justine Satterthwaite, Nicole Vinal, Sarah Whitfield, and special thanks to Rob Pareca, who has endless patience and never fails to answer my frantic calls for help as the lecture gets closer and closer. I also want to thank Soraya Omari and Judge Marcia Sikowitz, who spend this week helping me pull this off year after year. I want to thank our community partners, Bates College, Brunswick High School, Deering High School, the Maine Coalition to End Domestic Violence, Northern Light Mercy Hospital, Partners for World Health, the Rue Institute, South Portland High School, Tree Street Youth in Lewiston, and the Violence Intervention Project, all of whom made time for conversation with this year's speaker. She didn't get here till Sunday night, so it's been a busy 4 days. We also thank the Maine Monitor for being our media sponsor once again, and Lee Automals and my brother Adam for free publicity on public radio, and his videos from our recent trip to Uganda. We had the opportunity to visit Bundi, where our speaker is based, about 2 weeks ago, and we toured the nursing school, the hospital. We met the Batwa people who were in the video you just saw, visited several of the women's empowerment projects that our speaker has spearheaded, and managed to squeeze in 2 days of gorilla trekking. And thanks to all of you who've supported Justice for Women with your contributions and have taken the time to be here tonight. In addition to all of you here, we have people live streaming across Maine, New York, Brazil, South Africa, and a few other places. Lastly, I want to thank Jane's children. Where are they? Okay, back there. Jasmine and Japheth, who've shown extraordinary patience as we drag them from meeting to meeting to meeting, clearly proud of their mom and so incredibly well behaved, not to mention really funny. So now I have the honor to present this year's Courage is Contagious Award, which is given each year to a woman in Maine who raises awareness of injustices women and girls face locally and globally, is dedicated to empowering women, and has made a lasting impact in our community through her work. This year's award goes to a woman who does all of this and so much more, Nyamon Ngwani Mashar, known to many as simply Moon. Unfortunately, I got a call just a few hours ago from Moon, who sounded terrible and is suffering from food poisoning. And she was determined to try to make it, but in the end, she just couldn't. But let me tell you a little bit about Moon. She immigrated to the US from South Sudan at the age of 5 with her parents and 4 of her 5 siblings. Moon's father was a child soldier in South Sudan and left seeking asylum. Moon's early experiences with trauma left her with a passion to help others traumatized by war, by exile, and the everyday struggle for identity in the diaspora. This woman is everywhere in our community. She works with Disability Rights Maine, with people with psychiatric disabilities and other trauma survivors. She partnered with the state of Maine to co-create and co-facilitate a cultural competency course for service providers called Why I Can't Trust You. Late last year, she brought us Gospel Messiah, transforming Handel's Messiah into a reflection on migration, resilience, and the universal quest for belonging. She just launched a TV show which she co-hosts called From Away to Maine, interviewing interesting people from away who have found their way to Maine. Her inaugural guest was Dr. Nirav Shah, who's actually with us tonight with his wife, Kara. Thank you. Earlier this week, she interviewed Dr. Jane Anyango, who you'll hear from in just a few moments. Moon continues to use her experience as a refugee to inform her work with immigrants, with people struggling with mental illness, with young girls seeking to find themselves. She's an advocate, a role model, a mother to Omi, and a wonderfully warm, generous, and talented human being. Even though she's not here, I want you to join me in congratulating her, and I promised her we'd save the video. Thank you, Moon. Great. And now it's my pleasure to introduce the introducer. Marie Vino has a long history of working in delivery of healthcare in Maine. She's the president of Northern Light Mercy Hospital and is a board-certified nurse executive, as well as board-certified in healthcare management. She's a fellow of the American College of Healthcare Executives. Marie has spent her career in rural healthcare and is passionate about patients having access to high-quality healthcare. As president of Mercy Hospital, Marie serves as the liaison to the board and to the community, and she oversees the strategic direction, management, and quality of care. As a regional president, she helps build alignment between rural regional hospitals in Maine. Marie's connections to Maine run deep. She grew up in Millinocket and East Millinocket, where her father was a mill worker for 40 years. She was appointed CEO of Millinocket Regional Hospital in 2002 and provided steady leadership during a time of transition in the community. She joined what was then known as Mayo Regional Hospital in 2014 and added Critical Access Dean Hospital in the Moosehead Lake region to her leadership responsibilities when Mayo joined Northern Light in 2020. She is and always has been, and we know will continue to be, an advocate for women. Welcome, Marie. you.
Thank you.
Thank you, Kathy, for that very kind introduction. Welcome, everyone. So glad that you could be here tonight. Happy to be able to introduce our speaker, whom we hosted yesterday at Northern Light Mercy Hospital and found her to be engaging and informative, and I think you're going to really enjoy her talk tonight. So I hope you're looking as forward to it as I am. Dr. Jane Anyango is a distinguished nursing leader and educator from Uganda with over 20 years of experience in community health, domestic violence, and nursing education. Currently an assistant professor of nursing at Ball State University, Dr. Anyango specializes in maternal-child nursing, midwifery, education, and clinical research. Her work is deeply rooted in advocacy, focusing on gender-based violence prevention and the development of health policies for marginalized populations. Her career bridges the gap between high-level and compassionate frontline care, making her a vital voice in the global conversation on healthcare and justice. Would you please join me in giving a very warm Maine welcome to Dr. Jane Anyango.
Yeah, thank you so much, Marie, for that introduction. I feel sometimes I don't deserve it, but I'm really very privileged to, come here this evening. Thank you all for coming in. A special thanks to Justice for Women for, giving to me this opportunity to share some of the practices that we've used or some of the community-driven initiatives that we have used to solve rural health care or solve some of the burdens or some conditions that persist in our communities. A special thank you to University of Maine for giving us this room to come in and share this and come together and get to discuss issues around health care. Before I can move on to talk about the power of community in solving some of these persistent health issues in our communities, I'll share a video and then we'll move on from there. To all the people whom I've met and all the organizations that we've interacted with, I must say that together we can come in and solve these issues. So I'll have the video play first and then we can move on.
My turning point was in this forest. When I came to it, my life was changed. People come here and they learn from this place. It has so many opportunities. As long as you can dream of what you want, you can achieve it. This forest has all those avenues for change.
This is a community that felt neglected. There was a big shortage of healthcare providers. In addition to that, there were so many preventable conditions that the community faced. We were seeing a big number of patients struggling. Some of them were even lying on the floor, but most of them were dying in the community. I was the only registered nurse in this 150-bed hospital. Two Americans, Steve Wolf and James Jameson, came to the hospital. They looked at how this ward was so congested. They looked at the so few healthcare providers. And one of the things that they asked me at that time was, if you closed your eyes and opened it, what would you then wish for? So my response to them at that point was, you know what? If you could only help me build a nurse training school so that we could train more nurses, then we would be able to solve the shortage of healthcare providers. They promised to support me for my master's. I would then return and start this nurse training school from scratch. They supported the first operational cost of the school for the first 1 year.
I'd always wanted to be a nurse. My mom was the only nurse in the whole village. Our home was a hospital. I one time saw my mom deliver a baby when I was young. I saw men and women come at our home knocking at 3 a.m. My mother passed on from a hospital-acquired infection. And so I thought, I want to be like this woman when I grow up. I was looking for a school, actually. And can you imagine? I went to Facebook, and that's when I saw a young lady. She was dressed in the nursing uniform. And I asked her, I would like to join your nursing school. Before I know it, in August that year, I was here in Windy at school. I graduated with an advanced level in diploma in nursing. It did not only change my own life, it changed that of my family. And that is how we assess the baby for dehydration. It's a calling. You have to be called to serve. I will have a better day if I have helped a patient and they have a little bit more hope.
The nurses in Uganda sit for a national exam every year. When our students first sat, we had 100% pass. Second sitting, another 100% pass. In a period of 3 years, another 100% pass. So like, wow. Since the start in 2013, up to now, there are over 450 nurses who have graduated from this nurse training school. And majority of them have gone to support the community. So the vision grew up from a nurse training school to now growing it to a university. And I believe it's a model that can be shared across the world.
As long as you have an opportunity to serve, you serve with all of your heart.
So this evening we will just discuss, the power of community in solving some of these, persistent health issues, and some of the solutions that we've come up with from Uganda, and I believe we can share it in Maine. This afternoon I had a privilege to, get to interact with some of the council leaders or city leaders, and I was given a key. So, meaning that I can access anywhere and just bring in my ideas. So there is strength in the community, and initiatives which are community-driven can actually change the whole situation. If we focus more on community-based, interventions, we are able to sort out some of these, health issues. Communities define actually who we are. A community can be a culture, it can be a faith, it can be what we believe in, it can be just a place where we actually live in. And when we get into those communities and interact with those communities, they actually shape the kind of health initiatives which are put in those particular areas. And so when you get into this place and you focus more on how people behave, because a community is actually going to, it can be defined as a culture, right? So what happens is, then you can put in healthcare solutions based on how people behave in that particular community. And therefore, I can get back and say, community-driven initiatives are actually a pillar to most of these healthcare problems, or solving some of these healthcare problems. This is the community in which I grew in. And if you look down here, we have the nurse training school, and right up is the hospital. But if you focused a little more on the video that we had, you would see like some tiny buildings, and they're like mud houses. And so when you get into this location where this hospital is, or where the nurse training school is, which has now been upgraded to a university, you find that the community lives in such kind of buildings. So I grew up living in such kind of buildings, mud houses, and the roofs are actually like, they can easily be blown off. We don't have tornadoes in Uganda, but I think if we had, you would find like so many buildings are all like swept off. Anyway, so I grew up in this kind of community. And so we are a family of 5 children. And so my father died while I was 3. So I am, a second born. And I have 1 sister ahead of me and 3 others behind me. And so throughout, my life in this community, I kept observing a lot of things that I feel actually up to today has shaped the kind of solutions, the kind of initiatives, the kind of ideas that I come up with to be able to sort out some of the problems related to health in a number of these communities. So while growing up in this small community, every night, my mom would be waking up. But we're sleeping in this mud house, and I would say 1 room, and all the 6 of us would be sleeping in this house or getting down, all of us on the floor. Of course, not on one bed, but on the floor. And so I was always like close to my mom because we didn't have light, and so we would use a candle. So it will only light this other corner of the house. And so I always didn't want to like sleep far away from my mom because I needed this kind of protection. And so if my mom would get up, I would find myself also waking up and following her. But something was happening in this community that made my mom wake up almost every night. And so we would be hearing people shout, and this is a woman shouting in this community. And she's screaming for help. In Uganda, in case you have any issues, you don't actually call 911, but rather what you do is, hi, come and help me, come and help me. In fact, the communities are so close to each other that I would know around 25 homesteads, and I would be knowing what is happening in different communities. For example, if Jasmine, my daughter, was here, living here, and she left to go and play in the neighborhood, I would just stand and shout, Jasmine, come back home. And if she doesn't hear, another neighbor will say, Jasmine, your mom is calling you. And that's how she will come back home. So that's how the Ugandan community lives. And so every night, my mom would be waking up because she would be hearing this kind of, screaming and so on. And so for me, because I kept sleeping close to her, I would wake up and go with her to go and see what is happening in these homes. I was witnessing what was happening in the community. And actually, the thing that was happening there was domestic violence. the two people were fighting, and the woman would be shouting for help. And sometimes it could be in the presence of her children, the fight would be occurring in there. The same way we were living is the same way most of the communities were living. In the same room, you're fighting and the children are actually witnessing this. Sometimes you would find there are other family members who came in and they were like coming in to sort out all these other issues. Anyway, I'll stop at that one. But this was happening every night almost. I remember going and going and going. Now, this time round, an issue comes into our own home. At an age of 9, my sister falls sick. And so she gets this abdominal pain that kept on going for days. 2 weeks down the road, my sister was still having abdominal pain in the morning, in the evening, in the night. And it was so stressful to us because we're all sleeping in the same room, but she wasn't getting fine. And so she kept on crying. My mom tried all kinds of herbs, which is a very common thing in Uganda. So people to use all kinds of things, including leaves and all those kind of things. And it didn't work. So what happened is, after 2 weeks, she woke up and she's like, you know what? The two of you go to the hospital. I will keep home with the 3 kids. And so at an age of 9, I was like, okay, I will go with her because that is an instruction that we've got. And so my sister, who is 11, we begin walking. And we're walking miles, not 1 mile, but 5 miles. And so we kept on going and going, and she was feeling pain along the way. We kept on going until we go to the hospital. And when we go to this hospital, we found somebody dressed in white. I hope as you are focusing on this video, you saw myself dressed in a white dress. So the person who was dressed in white, the lady who was dressed in white, got my sister, gave her 3 tablets. I don't know what they were because I was 9 years, my sister was 11. So she gave my sister these tablets, and so my sister took the tablets and she told my sister to rest for some time and then we go. My sister fell asleep. And so I kept in there. She kept sleeping, and I can't tell whether it was for 30 minutes or 1 hour, but because we had had this pain, she was crying for, the whole night and so on. I felt like the sleep she had was really for a long time. Anyway, I kept moving close to her and I was like, are you waking up so that we can go? But she was still sleeping, so I left her. In my mind, things were just like running in and out, in and out. Anyway, she finally woke up, and the person, the lady who was dressed in white, who gave her the tablets, came in and said, you know what? You're ready to go home. Do you feel pain? And then my sister is like, no, I don't feel pain. And then I moved close to her again and I was like, are you sure you're not feeling pain? She's like, no, I'm not feeling pain. I was like, okay, let's go home. and so the person dressed in white, to my mind, I was like, oh, maybe this is a nurse. But maybe she was a nurse, or she was a physician, or she was whatsoever position she was holding at that time. All I remember is she was dressed in white. Now, because of being a lady and seeing how my community is organized, most of the women take care of the sick. And so I felt that any woman whom I would find at the hospital was a nurse. But for me, the only thing that came, to my mind was, she's dressed in white, and so I need to be like her. When we got home, my mom was like, are you okay? She's like, I'm fine. And you would see the happiness, how my mom's face just changed. And everyone was just relaxed because we knew we were going to have a good night's sleep. Anyway, so my sister was also there. So this time I was like, I hope nothing starts again. I hope the pain does not come back again. She didn't have the pain. We went on the next day. My mind was just like all running around. I was like, who is this person dressed in white who can actually make this pain go away? Pain that has persisted for 2 whole weeks. And my mom tried everything. She would put leaves on the belly and do everything. It wasn't happening. It wasn't going away. Anyway, so after like that whole week of thoughts, things were just going in my mind as a child. I told my mom, I told my mother that, you know what, I want to become like the lady who helped my sister. And I know this lady is a nurse. My mom just said, go on. But I think she said go on because we were poor. She would not afford to pay for me to go to a nurse training school or to a university and so on. But she was like, go on. And so I kept on like finding out, solutions. How would I really become like this person? I decided to start reading hard and thinking through everything that was taught in class before. And from an age of 9, I found myself like topping up the class. In Uganda, grades matter a lot, that if you're performing well, you're actually put as position 1, and people are given positions up to the last. And the people who are like topping up the class are often identified and given scholarships and supported to go on. So from an age of 9, I found myself like getting scholarships all through until I got into the university. When I got into the university, I decided to become a nurse. And so I studied my undergrad in nursing. When I finished up my nursing, to cut the whole story short, I'll not tell you what happened there, but when I finished up my nursing, I decided to think about going to the same community where I grew up from, so that I would help the same community that was facing the same issues, and probably anybody else who could have, such kind of issues like what my sister had would be helped. Or if not, I said I would want to go to a similar kind of community. In Uganda, all rural communities would be the same, and they'll be facing the same issues. You'll have to walk miles and miles before you can get to the hospital. Anyway, so finally, I graduate from this nurse training school, from this university, and I get a job. At an age of 23, I get a job in southwestern part of Uganda. That is how it appears now. And so I got a job as head of nurses and midwives. I have just graduated. There was a job posting on the North Pod, and then I applied for it. I was given. I was like, okay, I will go. Head of nurses and midwives, here I am. So I didn't go to this, I didn't get this job as head of nurses and midwives because I was smart as I was describing, but because there was a big issue in this community. There were no people to take up positions like those ones in that community, and there were no people qualified to my level to take up positions or to work in this hospital. Now, this hospital is located in a rural part of the country. And so, most of the people would go to this hospital, work for like 3 months or 5 or 6 months, and then leave to go back to the city center. Because you look for road networks, it was really poor. You want to make phone calls, you have to go under a specific tree. You want to read newspapers, you're getting it after 2 days. You want to transfer a patient to the nearby hospital, you go for 18 hours. So, and before you get into the next hospital, the next referral hospital, the woman dies along the way, or the patient dies before you get there. So there were just all these issues which were too much. And for me, here I am, head of nurses and midwives in such a community. And so what I did was, I did not give up, but I thought of a solution. Now, as head of nurses and midwives, I was the only one qualified to that level. And there were other 7 nurses, and these nurses were at a level of LPNs. LPNs are a little lower than the RNs. And so I was, of course, like now the most qualified nurse there. No wonder I got that position as head of nurses and midwives at an age of 23. Now, these 7 nurses were managing each and every unit within the hospital, so they would be in each of those. And now for me, I was the running nurse here. I would run to go to this place, run to go to this other. They try to put an IV line and they fail it. They're like, come and help us, and then I'm running in there. There are mothers who are giving birth, and there are others giving birth on the floor, and there is only one person, and they're like, come and help us, and you're here with so many mothers. Not one mother giving birth in a day, but maybe 7 or 8 or 9 giving birth in this hospital. And here is only one LPN, and therefore you have to come in and help. But it became a little hard because I would work from Monday to Sunday. In the night, they would be calling you. Sometimes you find yourself actually not even getting in to sort out because there is a patient dying. You just can't sleep. So anyway, I decided to think of a solution. And so what happened is there were girls who had dropped off school, who had dropped out of school. I think that's the right word. So they dropped out of school because they were not supported by their parents, and so they kept in the community. They were not supported to go higher in education because of how the culture, how the community treated girls, or how the community treated women. What happens is at an age of 13, the women are pushed into early marriage, or the girls are pushed into early marriage, so that there is a price that is paid. I'm saying 13 because I've ever delivered a girl, I've ever helped a girl who was 13 years to give birth. Anyway, so at an age of 13, what happens is parents push girls to get married so that they can get a bride price, which bride price is given to any woman who is married in Uganda, and that price is given to the parents, so the woman is actually forced into marriage. Sometimes these girls are so young that they cannot actually manage it, and so they are faced with lots of issues. They cannot get out of that because otherwise if you got out of this marriage, then what would happen is you would have to pay back this money. As I speak, I wasn't also like out of this whole issue. They paid a bride price for me as well. And so for myself, it was just like a lot of negotiations. My parents were saying, we want this. My husband's family was saying, we have this. And so it took them 2 days, but finally they agreed and they paid bride price for me. Anyway, so these girls were struggling in the community. Why? Because they did not go higher in education. And so we went in to use them because for me, all that I observed in the community is that women were taking care of the sick. And so we said, let us use these very women, bring them to the hospital, give them a basic training in healthcare, such that they can actually help the community because they live within the community. And also, they can help us like cover up. For example, if I'm in the children's unit and somebody is struggling out in the mother's, section and so on, these girls would go in and help. So we trained them in basic care. And when they went into the community, just as I said that the Ugandan community is so close to each other, so what would happen is they would come in and tell us any issues which are happening in the community, and then we'd go there and sort it out. And sometimes we'd also tell them that if you see a mother with a baby who is struggling in the community, for example, this baby has diarrhea and this baby is dehydrated, tell the mother to mix up salt, water, and sugar and keep giving to this baby until they bring the baby to the hospital. Some of those babies who were dying in the community as a result of those preventable conditions were actually surviving. So we brought these girls into the hospital and they supported us. In fact, you would find that in each of those units, we would put one LPN together with at least 4 of these girls, all of the women who had dropped off and we had trained in basic health care. Now, we formed a team of 52 health workers. We called them clinical support workers, and then there were nurses. Friends, I would want to tell us that the inverse care law is actually real. What happens is the people who need health care most are not able to get that health care. Those who are faced with a high burden of disease, which sometimes could be basic or preventable diseases, are actually not able to receive it. Instead, they will get the least support, just like this community. They were faced with a high burden of disease, but they were getting the least support. And that is basically what the inverse care law would actually describe. So after we had brought these girls and we saw that there were solutions, they were changing the health of the community. Things were changing. The number of people who were dying in the community were reducing. The number of people who would come into the hospital to seek health care were actually reducing because they would tell us, okay, there is this person who is bleeding, prepare to receive this person. And sometimes we would get into the community to save this person, or we would actually tell those people to bring the person into the hospital and we would be waiting at the entrance. We did this for a long period of time, and then we developed an idea of giving these ladies a qualification that would be recognized anywhere in Uganda and also across the world. So we thought of starting a nurse training school so that we could train healthcare providers, and particularly nurses, in a community which has been neglected. They will understand that community, they will learn that community, they will feel comfortable with that community, and later they would return and work in that community. So that was the idea that we worked up with, and so we started up this nurse training school. As you heard, the narration of how, the two Americans came in and they supported up. So that's how the nurse training school came in, from that whole vision. If you put your mind into something, it actually works. And that is how the hospital looked like or looks like, and you'll find all these other units. In the middle of nowhere, the community is served by that hospital. And that is the nurse training school, with all its structures coming up, to support many people. To us, we felt this was an innovation to solve some of the persistent healthcare issues. And for this time round, we were looking into shortage of healthcare providers in a community that was faced with a high burden of diseases, and particularly these diseases were preventable. These diseases did not require healthcare. Actually, now I keep thinking, maybe my sister had intestinal parasites, the worms just, and maybe she got that medication. But those kind of parasites are actually preventable if people ate nice or well-cooked food. And if people have no idea of that, then they'll just end up eating the parasites with food which is not properly cooked. The innovation is what helped this community. And so we thought of three major things. One, bringing a hospital right in the community where most of the people were not able to find this healthcare service. And therefore, we established that hospital, in the community hospital. We also thought about bringing in a nurse training school right in the community so that people can be able to, access training and remain and work there. Then we looked into the community. As I'd said before, the communities shape the kind of health services available. And sometimes even sustainability of these health services depends on how the community is organized or whatever the community believes in. So this community, as I'd said, had a high burden of preventable diseases like HIV/AIDS, like malaria, which is a common tropical disease, like all these intestinal parasites, like diarrheal diseases were coming up. Those are just basic, they are preventable diseases, and therefore if people got the right information, then they would be able to sort it out. Now this community was like burying people almost every day in the era of HIV. Almost every home was having somebody die on a daily basis. And so the people would not bury their own. So what they did was to form up what one would call a burial insurance. So the community organized themselves into a group that would keep burying. So today they bury here, the next day they join as a group and they go and bury in the next home. So we found that the community was already organized in such kind of groups. And so we utilized that and changed the whole picture. We said, no, instead of you bringing up insurance to bury the dead, let us now bring up this insurance or contribute to save or to contribute for health or contribute for healthcare, such that those who are not able to access healthcare due to cost can easily get it. So what happens is we used those same groups and we said, from these groups which have been organized, each person will pay $2 every 6 months. And I'm saying $2. Why? Because every Ugandan is able to live on less than $1 per day. So now you can think about affordability of cost of living and all these kind of things. So we said every person within that group would need to pay $2 every 6 months. And then if, say, for example, one person fell sick and the other did not fall sick within those 6 months, then the money is pulled from that pool and is used to actually pay for healthcare for the other person. So this helped and made people who were not able to afford for healthcare to actually come and access this healthcare. Now, those are the 3 major interventions that we actually used to be able to solve some of the healthcare issues in the community. That is the hospital down here, and that is the nurse training school to, I hope I'm able to the other side, to the top corner. And when you look in the surrounding community, that's how the community is arranged. In the middle of all these mud houses, all that stands out is actually the hospital and the nurse training school. The nurse training school, again, as I'd said, was placed there to reduce the burden of shortage or critical shortage of healthcare providers and particularly nurses in this part of the country. World Health Organization says, or has put forward, that at least you would need 1 nurse for every 500 patients. In this part of the country, it was 1 nurse for every 11,000 people. That was a big discrepancy and a big gap. And we felt that establishing this nurse training school actually sorted out. So the lower one in red is my current house in this, at this nurse training school or at the university. And that is how some of the structures are. And again, you will see the ones which are up are actually, the community structures. Now, with the establishment of this hospital, with the establishment of the nursing school, we couldn't do much more than looking for other innovations. The hospital is there, the school is there. So we looked into partnerships with quite a number of universities, quite a number of organizations to bring in best practices. We looked into use of technology so that we could be able to actually move with the current world. The hospital, there it exists, 120 to 150 bed hospital, which was started under a tree again, now ranked one of the best hospitals in the country, and it's one of the primary hospitals where the students would go for placement. We capitalized on that gold mine of insurance. That is how the outpatients of the hospital looks like, and people will always come. That is the waiting mother's hostel. Yesterday I was just interacting with a group of people, and they were saying they were coming from one of the islands, Peak Island. I hope that is Peak Island. And so we were chatting and having all these stories around, and they were saying that sometimes women will start giving birth and they give birth even in the boat, like along or in the ferry, in the middle of the water. And I was like, oh, you guys give birth in the boat? And you know what happens in Uganda? The women are living on the other side of the hill. They go on trying to climb and find the hospital the other side of the hill. So most of the time they're saying, no, this is a long distance. I'd rather give birth from the community. Or I'd rather try out all these other different hubs because it is very far to get to the hospital. Some of them will actually die along the way because by the time you get to reach where they are, you actually cannot save the life. If not that, some of them will come into the hospital, and by the time they get into the emergency room and so on, they are dying right at that point. So we felt like, okay, for the women who are struggling in this case, what could we do to make it better for them? So we say that we could have a waiting mother's hostel. So these women would come in, keep in the hospital for at least 2 weeks. During that time, they can access healthcare, they can interact with others. At any time they need a midwife or a nurse, they will be seen by them. And if you bypass like the room where they live in, you will hear them say, oh, my baby last kicked at around this time. And the other one will be saying, oh, for me, I feel like this. And so you will hear them talk and interact with each other. I feel it's the best experience for these women because they're there enjoying themselves, and at the end, they go home with nice babies. I wouldn't want to just get out of this situation before, or this discussion, before talking about the silent killer in the community. And this occurs in most of the communities. I talked about domestic violence at the beginning, and from a worldwide perspective, intimate partner violence or domestic violence exists. In fact, 1 in every 3 women will experience intimate partner violence. And up to 30% of women have been found. 30 out of every 100 women who are pregnant are found to be experiencing intimate partner violence during pregnancy. In the United States, 1 in every 4 women experience intimate partner violence during pregnancy. In Maine, 34% of these women will experience intimate partner violence. In a place like Uganda, I'm not sure whether it's lower than what happens in Maine. So they say up to 27%, but I can pretty much say that is not the right figure. Most of the people experience this intimate partner violence in the communities and are not reported, or they are not recorded. But intimate partner violence will cause many complications to these women. And we've heard about homicides, we've heard about all these deaths. In fact, in the United States, one can stand in and say 38 to 40% of the women who die while they are pregnant, that death is always caused by an intimate partner. In Uganda, the deaths are there, but not properly recorded. So I will not talk about that figure. This is an issue that affects people across the world, and it is common. It doesn't matter whatever qualification this woman could be having. It doesn't matter where they are coming from. It doesn't matter whether they are pregnant or not pregnant. It doesn't matter whether they are midwives or nurses or whatsoever, healthcare profession. You find that most people will be affected by intimate partner violence. Now, this condition persists in communities. And up to now, if I get back to my community, trust me, intimate partner violence still exists. But why? The basic answer to that is it has been made a normal part of most of the communities. People feel it's okay. And things like marital rape is not an issue in Uganda. So once a bride price has been paid, you are a property of this man. And so you have to give in to any kind of thing that the man will want from you. But the only way to overcome this is actually by coming together as a community and addressing these issues together. I'm so happy that in Maine there's so many organizations that actually look into intimate partner violence. And so if we come together with different kinds of solutions, I believe we can be able to sort out some of these issues in our communities. In fact, in Maine itself, Francine stated that she's coming from a Maine Coalition to End Domestic Violence. She stated that if at all we are going to solve this issue, we need to come together as a community. It takes a whole community to handle out some of these issues. So the power of community in solving some of these issues is important. Thank you so much.
We're now going to take questions. If people have questions they'd like to put to, as she's known in Uganda, Dr. Jane. We're going to sit over here.
Okay.
Okay. And you're free to stand up to answer questions if you're more comfortable.
Oh, yeah? Yeah.
Okay. If you have a question, come on down. Yes.
Thank you so much for sharing. My name is Holly Christensen. I'm a midwife at Mercy, who you visited today, hospital. I wondered what role administration plays and what kind of funding, what kind of oversight there is in a university, in your teaching hospital, in the hospital. Sounds like I didn't hear you mention anything about physicians. I wondered, are there physicians? And then what is the structure for administration?
Yeah. Thank you so much for that. In fact, the hospital had 2 doctors, physicians, because they would handle surgeries, they would go to the children's ward, they would go everywhere. And so one of them was the overall head of the hospital, and the other was managing out the pharmacy, the lab, and other doctors, not even other doctors, but other medical assistants. So I was head of nurses, and he was head of, the few other sections. In fact, we ended up getting married to each other. Because that is how small the staffing was. And so there was a community. So we had to find out solutions, some of these. Yeah, so there were only 2. And today, as we talk, as a result of collaborations, partnerships, technology, we're able to reach out to a number of partners or a number of people who can come in and support. In fact, you would have a pediatrician come in every 2 weeks to support up to now. That's what happens, and then goes back. And then they can be at a distance, and they're able to sort out, some of these issues. So that is what is happening even up to now.
One of the things that's been so interesting in the conversations we've been having with all sorts of healthcare providers in Maine is that in Bwindi, midwives and nurses deliver babies. And we've been talking about the acute shortage in Maine of these services. And out of these conversations have come the possibility of an exchange where nurses here might go there and see how that works, with the thought that maybe long-term there's a way to tweak the system here so that others can provide some of those services, because right now there's nobody. We learned that in Maine there are 11,000 births a year, the whole state. In Bwindi, in this little community in the middle of nowhere, there are 3,000 every year. So they get hands-on experience, which doctors who are in northern Maine or rural Maine don't get because there are so few births.
Yeah, and in addition to that, there are some other practices that we put in place so that we could multitask. So you find that a nurse who is graduating from this nurse training school is able to actually do obstetric ultrasound. And so we partnered up with the University of Vermont, the imaging section. And so what happened is they train out our nurses, throughout these 3 years of their training. And by the time they graduate, they can actually look into the belly of a mother to find out if there are any kind of complications, and they refer this mother as early as possible to, for example, a gynecologist, early before it becomes complicated. So the nurses who are graduating from this school are actually having skills, not only the nursing skills, but they come out also with sonography or obstetric ultrasound. And they've been able to sort out these complications way early.
She also asked about the structure, the administrative structure in the hospital.
Yeah, so we would have the head of the hospital who needs to be a physician or a family physician. And then we would have other surgeons coming in, but then we have the administrative bit, which has maybe the administrator of the hospital, but of course that person does not have the healthcare background. And then we would have other people like the logistic managers, the communications officers, the accountants, and so on, all of them coming to the side of administration. Yeah, but we would have the head of the hospital who has that background of medicine, and then others will come in as nurses.
The hospital was actually founded by an American doctor from California who went initially to do a health survey of the Batwa people who had been evicted from the forest in 1991 to create a preserve for gorillas and to attract tourism dollars. And he went with his wife, he sold everything, moved to Bwindi, and eventually founded this hospital. But he said the goal was, as soon as they could, to turn it over to be administered by people from the area. And he told this story that he's still involved, but it's run by people from the area. The staff came to him and said, we think if a woman who works here gets pregnant and she's not married, she needs to be fired. And he thought about it and he said, well, you know, it takes two people to make that pregnancy, and chances are, because we're so remote, that the man works here at the hospital. We have a first-class lab. We can do DNA and find out who it is, and we'll fire both of them. And they dropped the whole thing. So there are some cultural clashes that get resolved in very practical ways. Other questions? Maybe you could talk just a little bit. Yeah. Maybe you could talk just a little bit, Jane, about, hang on one second, Japheth, about your research that you did on intimate partner violence and what you found in Uganda, and then replicating that research in Indiana, what the differences and similarities were.
Yeah, so, you know, after I was having all these experiences of intimate partner violence or domestic violence in the community, I decided to look into factors which actually makes this intimate partner violence or domestic violence to persist in the Ugandan community. And so there were things like culture or an attitude where people have taken it as a normal issue. There are things like substance use and drug, drug and alcohol use as one of the issues contributing. Low levels of education is another issue that actually leads to intimate partner violence. Poverty is another thing that leads to intimate partner violence, or having no money. And unemployment is also another thing. And in fact, I focused more onto seeing some of those factors and trying to relate it with what happens in some parts of the US. And so I did the same study in Indiana, and I found out that actually they had the same factors. Yesterday, we had an interaction with, the other day actually, we had an interaction with some other people who are dealing with, domestic violence and intimate partner violence in the community in Maine here. And one of the girls actually stood up and said, I am working, but I am staying with my parents. Why? Because I cannot afford to live or parent. And so what I do is I keep on with my parents. Some of the women will continue to experience intimate partner violence because they cannot afford housing for themselves. And so they will keep in that situation. So poverty is a big contributor here. The same way it appears in Uganda is the same way it appears in the United States. Now, and that was an example from Maine. Now, I further looked into the available support for people who are experiencing intimate partner violence. And I realized that, the healthcare system is there to support. The judicial system is there to support. The police is there to support. The social workers are there to support. But then, these systems did not seem like clear to solve out some of these issues in Uganda. I came into the United States and tried to follow up that. I realized that there are all these bodies in there, but some of them are again not clear to support women who are experiencing intimate partner violence. So you find that people continue up experiencing this. We have some of these systems well structured, but intimate partner violence or domestic violence still continues. I further went into looking into why healthcare providers do not actually identify these women or pregnant women when they come into healthcare facilities
with full-blown signs of intimate partner violence. Like someone will come in with bruises, someone will come in with, a bleeding, but what a healthcare provider will do, they will first treat the bleeding and let the woman go home without finding out the actual cause of this bleeding. And yet, this actual cause of the bleeding could be because this woman was beaten on the belly by the partner. So I found out that healthcare providers were not getting those signs clearly in their minds. And so as people come in to seek healthcare, they're actually not sorted out, or they're not identified. There are some issues like, beliefs. Sometimes even healthcare providers themselves could be experiencing this intimate partner violence. And therefore, talking about the issue when you're also experiencing it, the healthcare providers will not talk about it. The systems or policies which do not support, the screening and identification and proper management. In fact, some of the healthcare providers say once they have screened and these people are identified, what is next? They don't know where to refer them. The same factors which are making healthcare providers not to screen are the same factors which are making the healthcare providers not to screen in Uganda. So whatever happens in Indiana is actually similar to whatever happens in Uganda. And in fact, we wanted to find out how many people report that they screen for every woman who is pregnant and has come to the healthcare facility for intimate partner violence. We found out that in Uganda, 56% of the people say they do not screen. We decided to conduct the same study in Indiana, and we found out that 44% of these people say they screen. The healthcare providers say they screen for intimate partner violence. And then 37% say they do not screen at all. Then 17% say they sometimes screen. So we decided to put those ones who say sometimes they screen. If you screen, just say you screen. Why do you say sometimes or sometimes I don't screen? So we put them together as people who do not screen. And so it comes back to the same value. 56% do not screen and 56% do not screen in Uganda. So the factors are the same, the issues are the same, and therefore we need to come together. I feel the only way we can do this is to come together as a community.
Yeah? Yes.
For being here. Separate issue, but related. I wanted to know if you could speak to family planning services and what you offer and how available contraception is for women in the community.
Oh. Yeah, another interesting topic altogether. Sometimes women will not have the right to actually get this family planning even when they need it. And so this is called the unmet need for family planning. The people who actually are supposed to be receiving this family planning, they know they need it, but they cannot get it. In Uganda, it's driven by so many things, including religion or how the community believes in family planning. In schools, you will not find like condoms given to students. In fact, it's a taboo to just display condoms because people will think you're promoting prostitution and all these other bad behaviors. And so healthcare providers will not easily take on these interventions into the community. Sometimes it's driven by just the religious beliefs. For example, the Catholics will believe that anybody has to go out there into the world and give birth, following the Bible. Go ye into the world and fill it. So you find that most of the people who believe like that will keep giving birth and giving birth. The hospital tried hard to put what is called whole institutional approach to family planning, because most of the people with an average woman in Uganda gives birth to at least 7 children. And some people have given birth to 11 children. In fact, my husband comes from a family of 11, and then the dad had other wives, so they are a family of 25 kids. Think about how such kind of families are actually managed. Now, the hospital came up with that idea of at least have everybody have an idea about family planning.
And so what we did was to put up condom boxes in communities and just anonymously allow these people go in and pick. These people would go there in the night and pick these condoms. And so we kept refilling them and refilling them and refilling them, meaning that there is that need, but there is something that is stopping people from using it. And that is what happens about birth control or family planning in the community. But with such initiatives that we take it into the community so that people can go and pick it in the dark, then it can help solve family planning. Otherwise, when they come into the hospital, usually the healthcare providers are trying as much as possible, and the women who are able to make decisions solely about family planning will get it, but it's still hard.
I think we have time for one more question, if somebody wants to ask another question. Yes.
I was in Botswana 2 years ago, and I was shocked because people don't speak with their tongue. Takes care of them. And they couldn't take a man home to date the person, because if they did, they would be forced. Yet I also saw a lot of women who were out of wedlock, and it all seemed to be around people denying, saying, no, these things don't happen. Is that what's happening? Is that because of the religion and because of all the practices for so many that there's this much resistance to even admitting the problem, violence?
Yeah, thank you very much for that question. And in fact, the culture has made it in a way that openly speaking about some of these issues is actually taken to be a taboo or a sign of disrespect. When I started my periods, I just couldn't open up to my mom. And I had to struggle all through to find my way, around all this. Because opening up into such kind of things are taken to be private. And so some girls, until they have fallen into issues, they've had boyfriends. In fact, they will not talk about the boyfriends they're having until they've gotten into trouble. So culture holds those things as a private issue. And so it has kept on putting girls at a lower level because they cannot approach their immediate parents, but instead they have to go on and approach the real elders, and that's where the grandparents come in. But sometimes grandparents are also busy. And so the grandparents are taken as community leaders who can now deliver some of these initiatives. And then I feel that actually, when we involve the community leaders, then we can solve some of these issues because grandparents are participating in majority of these.
Why don't you join me in thanking Dr. Jane? Thank you.
Sorry.
Did you have a question? Make it a quick one, okay? Because I promised we'd get out of here by 8.
All right, thank you. Thank you for being here, ma'am. Earlier you said your mother used herbs to treat illnesses in your village. I was wondering because sometimes traditional medicine and Western medicine clash. Is there any space in the Ugandan healthcare system to research traditional medicine and add it into the modern practice of medicine within your country?
Yeah, actually, and you know what? All these modern medicine come from plants. And the only thing is that they are used in a crude way, and they're taken in excess that it can actually cause death. So what happened is the hospital partnered up with the traditional healers, the traditional herbalists, the traditional birth attendants, and brought them together and said, we can work together and solve the community health issues as a team so that you give the right quantity, and in case there are issues, you're able to bring this to the hospital. Thank you.
As always, This week has been a whirlwind. Dr. Jane has spoken to hundreds and hundreds of high school students. She met at Deering High School with the Future Medical Professionals Club, and then followed with an auditorium full of students. She spoke to several classes at Portland High School, South Portland High School, a packed library full of students, where she was interviewed by aspiring healthcare workers at Brunswick High School. Students, faculty, community members at Bates College had questions for her. At each school, she answered dozens and dozens of questions, like, what were the best moments and the worst moments of being a nurse? And my favorite was, how much did your husband pay for you?